Good afternoon, everyone, and welcome back. We have a fantastic session for you all today that's focused on the natural history study and also the clinical consensus guidelines. So before we get started, I will share a brief message from our sponsor, and then I will introduce our first speaker.
Our mission at Jaguar is to accelerate breakthroughs in gene therapy for patients with severe genetic diseases.
With gene therapy, we can give the opportunity at a better life. That's what makes Jaguar special.
So without further ado, it is my pleasure to introduce our first speaker, Dr. Alex Kolevzon, who many of you know. Dr. Kolevzon is a child and adolescent psychiatrist and professor of psychiatry and pediatrics at the Icahn School of Medicine at Mount Sinai. He has done extensive clinical research in PMS. He has published some of the most important work on characterizing and managing PMS. He's led multiple clinical trials in PMS. He's an active member of the PMS Neuropsych Consult Group, of the PMSF Medical Advisory Committee, and the Clinical Consensus Guidelines team. He's actively involved in education of the community, and he's a mentor for our recent Young Investigator Award in Neuropsych. Last but not least, he's the principal investigator for the Mount Sinai site of the Natural History Study. Welcome, Dr. Kolevzon.
Thanks, Kate. It's very nice to be here. It's also very nice to hear somebody read a bio that I didn't provide to them. So you did your own homework there. So we're going to divide up this talk, and I thought I'd give an update on the natural history study. We developed this developmental synaptopathies consortium, 2014, maybe. I think that's around the time. And the goal was to really have a better understanding of the clinical characteristics of Phelan-McDermid syndrome, and then really importantly, to track the natural history over time using repeated measures. We also had an aim to develop specific biomarkers using neuroimaging. And we wanted to understand whether there were other genetic factors across the genome that may also impact the phenotype. The natural history is really a critical goal. The purpose of this consortium, the main purpose, was to develop a network that would be ready to start clinical trials once exciting new treatments kind of came down the pipeline, and we were ready to really test things in a very kind of definitive way across multiple sites. We wanted to develop sites that were comfortable collaborating together, sites that had developed expertise around working with kids with Phelan-McDermid syndrome. So the natural history is really important as it relates to clinical trial readiness, because you need to really have a good understanding of what the clinical characteristics are, what we call the phenotype. You wanted to be able to identify specific targets for therapeutic interventions. So there's lots of different symptoms, but not necessarily every symptom is appropriate for a clinical trial in terms of measuring. We wanted to better understand which kinds of demographic, genetic, environmental, or other variables that really correlated with disease outcomes. And then the goal was finally to kind of inform best clinical practices. That's where the clinical consensus guidelines will come in, and Sid will talk about that later. So we really had an enormous amount of success. This study recruited beautifully, thanks to the community and to the foundation. We enrolled 101 participants. That was really our goal. We completed 100 comprehensive in-person assessments. This is obviously pre-COVID at baseline. And then there was a really great kind of retention, right, where the goal, because it's a natural history study, is to do repeated assessments. So at 12 months, 92 people continued to participate. And at 24 months, 90 people continued to participate. And actually, this is a goal of ours going forward. Everyone that was participating in this DSC1 phase, we want to continue to be able to assess essentially on an annual basis. I think what's happened over time is become much more challenging for people to come in. And obviously, there's been an enormous amount that's gone on in the environment since then. But we do want people to continue to participate because we learned so much. And as an example of some of what we've learned, many publications have now come out of this. So we're better understanding the impact of these very small, what we'll call point mutations or sequence variants, how they relate to larger deletions. We're learning a lot more about how the clinical characteristics might change over time, especially as people reach adolescence, and some of the neuropsychiatric symptoms we're seeing. We're learning more about regression. And we're also learning more about which measures we use to capture different clinical symptoms and which ones are relevant to Phelan-McDermid syndrome and which ones perhaps are not as relevant. So the social responsiveness scale, this last study here, is a very commonly used instrument to measure autism symptoms in autism. But we found really that in Phelan-McDermid syndrome, it probably isn't quite as relevant, and that we really clearly need to develop new scales that are tailored more to children who are minimally verbal with intellectual disability, and more specifically around the Phelan-McDermid syndrome phenotype. Neuroimaging, and Sid's really taken the lead in this. We performed 18 MRIs. These are challenging things to do. Did a volumetric analysis of the basal ganglia, which is the section of the brain that's responsible for sort of coordinating movement along with the cerebellum. And a couple of publications have come out here. What we found was that patients with PMS had actually decreased volumes in the structures that make up the basal ganglia, and that actually cerebellar volume is decreased, and it was related or correlated with the severity of repetitive behaviors. That's kind of an interesting finding, the idea that a biological marker can actually be correlated with clinical symptoms. And I'll keep coming back to that. And then DTI, or diffusion tensor imaging, looks at the integrity of white matter, which are sort of nerve fibers deep in the brain. And looking at the tracks that underlie social cognition, Sid found that there were significant changes in the integrity of those nerve fibers on both sides of the brain. So we're just sort of starting to learn, more and more through these kinds of studies. One of the third aim was to look at other genetic hits essentially across the genome and to see whether that was having an impact. That was a really kind of lofty goal, and ended up being relatively low yield. So using things like whole exome sequencing or whole genome sequencing, I mean, the idea that we're going to find a significant number of kids with Phelan-McDermid syndrome will also have additional genetic changes outside of the end of the 22nd chromosome that really have an impact on the phenotype is unlikely. These are going to be rare second hits. But Michael Breen from Sinai started to do more kind of transcriptome or metabolome types of analyses, and he started to look at sort of gene profiles very broadly, and found that about 537 genes are strongly associated with social withdrawal and Phelan-McDermid syndrome. So that's an exciting finding, that genes kind of broadly map to pathways that we know are very important, like chromatin binding, and then of course the mTOR pathway, which is related to TSC, which is part of our development synaptopathies consortium, and then IGF-1 signaling. And IGF-1 is another potential therapeutic, actually, that a lot of people are becoming interested in. One of the key questions also as it relates to genetics is whether that we can sort of predict based on the genetic changes what the clinical picture might look like. And one of the very kind of crude ways of potentially doing that is to divide people up into either small deletions or just sequence variants where only SHANK3 is affected versus larger deletions. And this is what's called class 1, as we defined it in this paper anyway, where class 1 are the sequence of variants and the small deletions, and class 2 are the larger deletions. And this paper was a really important paper where the DSC contributed a lot of the data. There were, I think, 170 patients that were included in this study, at least 100 of whom came from the DSC. And again, a lot of really important findings, and I'm sure this has been distributed, but I'm happy to distribute it if not. But kind of in totality, what we found was that kids with smaller deletions and sequence variants are much more likely to develop single words and phrase speech. They're more likely to walk earlier and to have higher cognitive abilities overall. But at the same time, kids with smaller deletions and sequence variants are more likely to show regression in language. And of course, that might very well just because these are the kids that were more likely to develop language in the first place. But this group was also more likely to develop more severe mental illness, especially later in development. So another one of the big kind of accomplishments of the DSC-1 was to create a contact registry. So we developed a DSC contact registry for the PMS community of patients, families, researchers, and physicians. We now use a large data management core, which has been really valuable in being able to share data across researchers. Phelan-McDermid Syndrome Foundation has been super helpful in funding additional studies, both of electrophysiology and studies in understanding the phenotype in adults. And both those studies, actually, results from them really served as the basis for the renewal of the DSC grant. So we're now on to the DSC-2, and in many ways, the NIH was willing to grant the renewal because of the success of the DSC-1, and to a large extent because of the support of the foundation in sort of pilot in providing the funding for these additional pilot studies, so we can kind of really, grow our aims and such. So in the DSC2, we continue to really have this main goal of comprehensively characterizing the phenotype across the lifespan. We expanded what that lifespan meant. So the first DSC was really 3 to 18 years old. And we realize now, of course, we want to capture many, many more kids and adults. So we've gone down to 18 months and we've gone up to, I think, actually no age. Anybody at all ages, we're happy to have them participate. We shifted our goals from imaging as a biomarker, which obviously is still quite important, but very challenging to do and also quite expensive, to neurophysiology using things like electroencephalography. And then we wanted to keep this clinical aim of trying to really push clinical assessments forward, develop tools that were perhaps more sensitive for Phelan-McDermid syndrome for clinicians to use in the community, and then to really enhance and update the consensus guidelines, which Sid will talk about. So the Developmental Synaptopathies Consortium 2, we have five sites, continued sites at Rush, Boston Children's, NIH, Stanford, and Mount Sinai. The goal is to recruit 190 participants. And we're going to see people basically for 4 years. The second group will be seen for 3 consecutive years, and we'll continue to follow the kids that were initially recruited as part of the DSC1. But this is going to be a really huge database. We're, I think, about 70% of the way there in terms of recruitment. We just had a meeting today talking about the challenges that we face and trying to think about ways to encourage the community to come participate, especially those who participated in DSC1. We want to keep seeing these folks. But the data that we are gathering, I think, has been really valuable. We've learned an enormous amount. We're collecting many different measures across many different domains. So we're measuring cognitive ability, adaptive behavior, and language, and motor functioning, and autism symptoms, and all kinds of other symptoms like sensory symptoms and sleep. We're putting a lot of focus now on trying to better understand regression and who's at risk of regression. We think that even though this is, research assessments, we do provide reports to kind of summarize what we've learned, and we are able to give them back to families, which we think are extremely useful clinically, and hopefully useful in terms of advocating for more services for kids. So even though it's research, we do think that there's some real benefit to it, and we hope people are willing to participate. We've developed some brand new tools, in part out of the work of the DSC. So Paige Seifert, the chief psychologist at Mount Sinai, has created the first known assessment that combines a clinician-administered observation with a caregiver interview to measure sensory symptoms. In many ways, the unique kind of sensory phenotype in Phelan-McDermid syndrome was a real driver for the creation of this instrument. She's now published this tool across a couple of different conditions, but there have been 3 separate studies that have looked at it in Phelan-McDermid syndrome. We think it's beneficial not just for research, but also for clinical purposes, and it's being used now across all the DSC sites, hopefully. And one of the interesting things that have come up is this unique phenotype where, using the SAND in particular and actually replicating previous studies, we've shown that children with Phelan-McDermid syndrome show significantly more sensory hyporeactivity as compared to idiopathic autism, and certainly as compared to typically developing kids. And that's a finding that I think is probably obvious to all parents, especially given the high pain thresholds that they often see with their kids. But to be able to capture it in a really kind of standardized measure, especially measure with an observation and some more objective kind of ratings, has been really valuable. And the next step is to make sure that this is also going to be sensitive to change over time. And we already have some evidence that in the context of treatment, there is actually improvement on this measure, if there's improvement with the intervention, obviously. But this is an exciting tool. Similarly, Sid led a project using the repetitive behavior scale, which is a common tool used to measure repetitive behaviors in autism. And he found that actually in Phelan-McDermid syndrome, repetitive behaviors were actually much lower than in autism more broadly, and that was regardless of IQ. So we're kind of learning where this tool is relevant, where it's not as relevant. How does Phelan-McDermid differ from autism more broadly, and so on. So these are, again, valuable things to learn. And I mentioned this already, that we took the social responsiveness scale, we analyzed how it performed in Phelan-McDermid syndrome. We found that actually it wasn't a fantastic tool for a variety of reasons. In preliminary data using the whole DSC, this includes both PMS, tuberous sclerosis, and P10. we looked at the rate of regression using a regression supplement and found that 38% of caregivers indicated that at least one skill had been lost at some point. 36% reported that the skill was in the social communication domain. 14% reported that one motor skill was lost. And overall, the most common skill to be lost was a bad one. So we're really kind of honing in on this idea of regression, better understanding it in terms of where it's most likely to occur in development, what it looks like, how is it different in Phelan-McDermid syndrome compared to other conditions, because it's obviously also common in autism broadly, and as we see here in tuberous sclerosis and P10 as well. How am I doing with time, by the way? It's 4:20. What am I going to here, Kate?
I have about 10 minutes.
10 minutes, okay, cool. And I'm on, okay, it's 17 to 26. So neurophysiology, this is stuff that it uses EEG measures. This is where you connect all those electrodes to the brain and you're looking at electrical signaling. I guess I'm going to try to, I'll present some of the findings. I think it's really important because we've done so much work in this area and published a number of studies. I think that as you're thinking about this, I'm going to have to convince you of why it's really clinically relevant and why it's so valuable for use in clinical trials. And I'll go slowly and then I'll go more quickly just because I want to give you a flavor of it. But one of the things that we're most focused on is something called visual evoked potentials. So these are non-invasive techniques to evaluate the functional integrity of visual pathways. It's recorded just with 3 electrodes attached to the scalp, and it's recorded in response to a visual stimuli, which is a contrast reversing checkerboard. And so what happens is the VEP, or the visual evoked potential, reflects the sum of excitatory activity in the brain and inhibitory activity in the brain. And there's these corresponding peaks. So I think if you can see my mouse, right? You see my mouse on the
Yes.
right? Yeah, okay, there you go. God, I have to double check everything now. So you have these corresponding peaks. So this peak at N75, this is a typical kid, and it doesn't matter if the kid is an infant or actually if the kid is an adult. This is a very well replicated response to this visual stimuli, and in typically developing folks at any age, you see these 2 peaks. And this first peak here at N75 reflects excitatory activity, and the second peak reflects kind of an inhibitory response, essentially. And remember that excitatory activity in the brain is driven by a chemical called glutamate, and SHANK3 is an anchoring protein for glutamate receptors. And so as you might predict, based on that biology, in Phelan-McDermid syndrome, what you see is kind of a real decrease in the initial excitatory peak, and then as a result, a decrease in the inhibitory response. So it's a kind of a flattening of this curve, which is very replicated and very consistent in Phelan-McDermid syndrome. And so it can be what's considered to be potentially a biomarker. And it doesn't matter if you compare kids with Phelan-McDermid syndrome to idiopathic autism, to siblings of kids with Phelan-McDermid syndrome, or typically developing controls, you're very consistently going to see this kind of flattening peak. And it reflects, again, decreased excitation or decreased glutamatergic activity. And so why is it important? It's important because it might be that in the context of a clinical trial, if you were to do repeated assessments and the drug was to provide some growth, for example, or increased excitation, you should be able to measure it on the VEP. So it ends up being totally objective because it's quantifiable. And we do know that over time, the VEP is consistent. That's one of the things that we're looking at very closely in the DSC-2. And also important, and this is the kind of the place where you have to think about why is it clinically relevant. It's not just about electrical signaling in the brain, it's actually about clinical symptoms, obviously. And so as you can imagine, the response on the VEP is actually correlated with sensory sensitivities as well. And so what you see in the figure on the right is that decreased excitatory drive or excitatory amplitude is associated with more sensory hyporeactivity. So the more severe your hyporeactivity, the smaller that excitatory peak is going to be. And again, those things are important because a biomarker is really only as important as it's related to a clinical symptom and as it's relevant in terms of designing the clinical trial. So the hope is that we will have sort of better biomarkers to be able to either predict treatment response or track with treatment response in a more objective way. Auditory event-related potential, so that was a visual one. You can do different types of stimuli across different types of domains, including auditory domains. This is work done by Jen Foss-Feig at Mount Sinai, which actually shows that compared to when you compare Phelan-McDermid syndrome to idiopathic autism to kids with typical development, they actually all show pretty robust responses, and they're very, very similar. And you see the overlapping of the lines, which suggests that this particular measure may not be ideal as a biomarker because there's not a lot of distinction, or it may just be the way that we've set the paradigm up. It needs some work. But if you look at just within the Phelan-McDermid syndrome group, there might still be some utility to this measure because actually the N1 amplitude, one of the first peaks, was correlated with sensory sensitivity on the sand. And it was also correlated, and the second amplitude, I think, the P2 habituation measure was correlated with the severity of autism symptoms. So again, sort of interesting ways of trying to parse these data in an effort to develop more objective measures to incorporate into clinical trials. April 11 from the Boston Children's Group has been looking at baseline EEG. So this is without a specific stimuli. You're just measuring at rest essentially. And so this figure shows normalized EEG power in Phelan-McDermid syndrome patients and controls, and that overall patients with PMS have lower alpha power, higher gamma power than controls. And then actually she sort of separated out kids with Phelan-McDermid syndrome who had autism versus those who didn't have autism and didn't see significant differences. So I think this idea of the importance of the autism phenotype may not be super relevant for clinical trials, for example. These are more baseline EEG data that to show that basically individuals with Phelan-McDermid syndrome demonstrate a positive overall phase bias, whereas typically developing individuals demonstrate a negative overall phase bias. It gets super complicated, and I'm actually on this paper and still have trouble understanding it. But what we'll do is have a whole nother talk with April, and she can explain it to you. And then finally, and I'll wrap up here, we've been using a checklist that was developed in tuberous sclerosis, and we're trying to kind of adapt this checklist with the idea that maybe in community practice offices, when you bring your child in with Phelan-McDermid syndrome, rather than the doctor saying, "Oh, I've never seen a case of Phelan-McDermid syndrome before, I have no idea what to do," and they turn around, they look on their computer and they start to Google stuff, they'll actually have like a tool that could be used to sort of assess symptoms, and even basic stuff like, developmental milestones, current level of functioning, behavioral concerns, intellectual abilities. So we're really trying to kind of think about user-friendly, clinician-friendly tools to make sure that children are assessed comprehensively, and we really understand the whole breadth of the phenotype. And this is just one example of behavioral concerns that often get overlooked in the community, but are obviously especially important to me as a child psychiatrist. But like, does your child have anxiety? Do they have depression? Are they extremely shy? Are there mood swings? Are there aggressive outbursts? These are things that often go overlooked, and we think that they should be emphasized, especially in sort of routine, physical health monitoring in the community. That's one of the ideas behind sort of adapting this particular checklist from tuberous sclerosis to refine it so it's much more specific to the Phelan-McDermid syndrome phenotype. And with that, I am done.
Thank you so much, Dr. Kolevzon. That was amazing. It's great to, get a complete summary of all that we've learned. And as Dr. Kolevzon mentioned, a big thing that's really important about the natural history study is collecting data for outcome measures in clinical trials to test if drugs are really working or not. So in the future and currently, you can find all of the information about the natural history study and how to enroll on our website and on social media and in our newsletter. And thank you for your participation, because every family that has participated has helped us learn all of this. So it's really amazing to see the summary. So next, I would like to transition and introduce Dr. Sid Srivastava. He's a child neurologist and neurodevelopmental disorder specialist at Boston Children's Hospital. He studies genetic causes of intellectual disability, autism, and regression, and has a special interest in Phelan-McDermid syndrome. Like Dr. Kolevzon, he's been a long-standing researcher in PMS. Recently, he has studied neuroimaging as a means to assess cognition and behavior in PMS. He also plays active roles on the Neuropsych Consult Group, Natural History Study, and in the development of the clinical guidelines. He's an active member of our community, and we're so thankful he could join us. Welcome.
Thank you so much. First off, can you hear me okay?
Yes.
And can you see my slides okay?
Yes.
Okay.
Apologies to Alex for the hiccup. It was so natural that I just thought
It really was. I thought that Alex decided, let me just skip the slides, do this intimate conversation with the entire community at large. So I honestly thought you decided to forego the slides because of a conversation, but it was that natural. Anyways, thank you so much. I'm really excited to talk today. I'm going to talk about our efforts updating clinical practice guidelines for Phelan-McDermid syndrome. And I think this is a really, really much needed effort that I think would benefit not only the medical community and the scientific community, but perhaps most importantly, the family community at large. As many of you know, in 2014, Alex spearheaded efforts to develop initial clinical guidelines for PMS, including monitoring and assessing different medical domains such as neurology, endocrinology, cardiology, gastroenterology, nephrology, and primary care. I won't review all of these different areas in detail here, but the PMS Foundation has created this really nice infographic summarizing these different recommendations in these different domains. Alex published these guidelines in 2014, nearly a decade ago. And since then, a lot of stuff has happened. There's been a relatively large number of published studies on PMS, including interventional and clinical trials, large-scale genotype phenotyping studies, including the one that Alex mentioned, deep dives into the neurobehavioral phenotype of PMS, as well as other studies from the DSC, which Alex presented on. Because of all this collective information, our collective knowledge about PMS has certainly increased and improved. It's certainly not perfect, it's certainly not complete, but it certainly has expanded over the years. The other aspects of this is that our collective clinical experience has also increased significantly over the years. And what I mean by that is that we've seen patients, we've provided care to families affected by PMS. Not only this adds, I think, to our knowledge about PMS and range and severity of phenotypic presentations as it relates to PMS. It also increases our knowledge about interventions that could be considered, which may work or which may not work or may be less likely to work in this patient population. Related to the first point that I mentioned about expanded research knowledge about PMS, I wanted to highlight a couple of papers focusing on regression in PMS, which is a very hot topic, understandably. The first paper I wanted to point out comes from 2017 and looked at about 40 individuals with PMS using questions about regression from an instrument called the ADIR. Regression was present in about 43% of cases, according to this instrument. The average age of onset was around 6 years of age or so. 39% of those who experienced regression, there was a regain in some skills. This paper also looked at different factors that could predict, that could be related to regression, and seizures or abnormal EEG was not associated with regression, and deletion size also was not associated with regression in this paper. More recently, this was a study led by Dr. Tazy Kohlenberg and Alex involving clinician-administered semi-structured interviews focusing on different neuropsychiatric symptoms in PMS. There were 38 participants, individuals with PMS, who participated in this study. The average age of the participants was around 24 years of age. The onset of psychiatric symptoms occurred at an average age of around 15 years. I should note that there was an overrepresentation of females in this cohort, as well as those with a particular type of mutation, point mutations in this cohort. The initial presentations were marked by significant changes in mood. So there is a significant prevalence of mania, and there's also significant prevalence of depression. Catatonia was also commonplace in this paper. Symptoms suggestive of catatonia occurred in about half of the cases. Triggers included things like infection, changes in hormonal status, stressful life events, and so on. What these two studies have emphasized really is that there are a lot of individuals with PMS who need help and guidance about what to do, especially when it comes to these challenging neuropsychiatric presentations. This actually has been the impetus for the formation of the PMS Neuropsychiatric Consultation Group, again, led by Alex and Tacy Kohlenberg. Project ECHO stands for Project Extension for Community Healthcare Outcomes. So this is an overall initiative that is designed to improve access to knowledge for different conditions, particularly ones that are rare, that are complex, for which there may be a limited number of clinical experts who are familiar with this group, with that condition or group of conditions. Project ECHO consists of a series of different video conference calls with providers who have challenging cases. And also these providers present to a panel of clinical experts. Before the call, the referring provider summarizes the case and comes up with a list of specific questions and concerns. During the call, the exchange is very interactive, very collaborative. The clinical experts listen to the case, ask questions, and then come up with specific advice and recommendations that the referring provider can go home with and implement. The PMS Neuropsychiatric Consultation Group, as the name suggests, applies this model, this Project ECHO model, to challenging cases of individuals with PMS who have complex neurobehavioral neuropsychiatric presentations. The team consists of a wide range of different PMS experts spanning multiple countries, also spanning multiple disciplines, including neurology, psychiatry, neuropsychology, sleep medicine, and many others. One of the really nice accomplishments, I think, of the PMS Neuropsychiatric Consultation Group has been the creation of different treatment algorithms for different types of neurobehavioral symptoms in PMS. These symptoms include things like ADHD or attention deficit hyperactivity disorder, irritability or aggression, anxiety, mood cycling, sleep disturbances, catatonia. These recommendations are not evidence-based per se, meaning that they're not based on large-scale clinical trials. They're not based on research studies, but rather they reflect kind of expert consensus opinion. On the right is an example flowchart showing the algorithm for ADHD or ADHD-like behaviors in PMS, for example. And these algorithms are publicly available at the link shown below. Project ECHO, of course, has been a really terrific initiative, but it's focused on neuropsychiatric symptoms. And of course, the question is, well, what about all the other systemic facets of PMS? So going back to our update of clinical guidelines for PMS, we had one major goal in mind, which was to establish updated guidelines, recommendations for clinical management of PMS, which, number one, reflect the latest in knowledge about the disorder, and number two, which provide guidance for clinicians, for researchers, for the general community. The chair of the practice guidelines is Alex, and I serve as the co-chair. We designated major domains to focus on, including psychiatry, neuropsychology, neurology, dentistry, cardiology, gastroenterology, nephrology/urology, physiatry, endocrinology, clinical genetics, primary care, and I didn't include in the slide here, but also OBGYN. And I've listed the leaders of each of these sections on the right. I think it really goes without saying that family involvement in this process has been absolutely critical. Family representatives have taken part in many of these subgroups. The initiative is, of course, with partnership of the PMS Foundation, who have been terrific in supporting us. And I think we wouldn't be able to get this initiative launched without all of their support and help. What about the structure of the guidelines? So basically for each of these major areas, such as psychiatry or neurology, et cetera, we're presenting an overview of common disorders or domains of impact. We're talking about developmental considerations when applicable. For example, some problems arise in the early developmental period, whereas other problems can arise in later developmental periods. For each of these major areas, we're also presenting recommendations for assessment of the major problems, how best to monitor these symptoms, and also we're providing suggestions for treatments or interventions when possible or where applicable. So where are we in this process? The idea for these guidelines, updated guidelines, started in about 2019 or so. We formed leaders of this task force and subgroups in 2020. Between 2020 and 2022, the subgroups have been meeting pretty regularly. And in January of this year, we completed a first draft of these guidelines, and we've been revising and iterating and revising continually since then. I don't have an exact date for when we'll try to submit this for publication, but we are actively working on this to get this guideline document out as soon as possible, or within a timely fashion. Finally, just to acknowledge a lot of people, a lot of personnel who've been involved. Of course, the CVER team at Mount Sinai, the Boston Children's Hospital team, the Neuropsych group, the PMS Consortium, the NIH, the PMS Foundation, and I think most importantly, the families. We learned so much from the families out there. We learned so much from each and every participant, every individual, and I think every interaction with the family, I'm always learning something new, and I really cherish that kind of sharing of knowledge. And it's a real privilege to take care of the patients, of the individuals. And anyways, thank you.
Thank you so much, Dr. Srivastava. So we have some time for questions. Please go ahead and put any questions in the Q&A and not the chat. It's a little bit easier to manage them there. Thank you for that great update. And I see we have a couple questions rolling in. Before I can read them, I actually have a question that I get a lot in my inbox that I think I could pose here, which is that my child, potentially has behavioral, we have concerns about the ability to stay still or moving around for a lot of these assessments. What would you say to a family that is concerned about enrolling in the natural history study for that reason?
Great, that's a great question. So yeah, I think maybe both Sid and I would answer that together, but this is what we do, right? I mean, we focus on children with developmental disabilities, and all children have challenges trying to do these assessments. And there's nothing worse for a parent than to watch their child sort of flounder during an assessment when they know the child can actually do the things, they just can't do them necessarily in the clinic. So we take our time and we spend hours and hours and hours, and sometimes, to the burden of the families, trying to get the best performance out of these kids so that we can make sure that they reflect their actual abilities. But if they can't do an assessment, we don't do the assessment. We're not going to torture somebody. I mean, there are definitely like language-based assessments that we have where if the child doesn't have language, we're not going to keep, hammering away at that. It just doesn't make sense. So I think this team anyways, is really sensitive to the special needs of kids with Phelan-McDermid syndrome. So we're pretty sensitive to that.
Great, thank you. And this question from Andy is a good question about clinical guidelines. How do you include central themes of clinical needs that do not fall under major domains? The two themes that come to mind are pain and communications.
I can get started, and Alex, if you feel free to add in. So that's a great question. We do include communication, language and communication under the neurology, neuropsych group, which is extensive. I don't know if we talk about pain specifically, and I'm also reflecting in the neurology section if we mention that as well. But Alex, what are your thoughts about the pain question?
Yeah, so pain, to me would fall under sort of sensory sensitivities. I think we might mention it in the psychiatry section. It would be appropriate also for the physiatry section. We have a whole section on physiatry. But that's a great comment, and that's why we include family members in these groups. And that's something we should probably circle back to make sure we do include, frankly. That's part of the reason why you see this taking so long, is because the amount of things to cover that are so important just keep popping up, and we keep, being reminded of things that we essentially forgot. In fact, I saw Lori is on this call. She's now our OBGYN expert. So, I mean, remarkably, we put this whole group together and neglected to include, basic women's health issues. And so that's now then included kind of in the 24th hour.
Thank you. I imagine there's also a bit of overlap between the domains, including just in GI, we know there's a lot of, pain and discomfort associated with that. So I'm sure there's a lot of, overlap.
Yeah.
Next question is, has the research determined the best approach for treating epilepsy?
That's you said.
Yeah, sure. Yeah. So there's certainly been different studies looking at epilepsy features in PMS. So Jamie Holder in Baylor in Texas is an epileptologist who studied PMS and looked at different epilepsy features within PMS. So right now we don't have any practical guidelines about what medications may be especially helpful for children with PMS who have epilepsy. In other words, the treatment for epilepsy in PMS follows the same kind of standard of care for epilepsy in general, so that we at least at this point, based on what we know, we don't have any specific guidelines about epilepsy treatment in PMS. But I think we have all this data that we're collecting and analyzing, and I think we should and are trying to look at that to see if there could be some medications or some medications in particular that may be more helpful for seizures or epilepsy in PMS.
I'll make two non-seizure expert comments. One is that I don't think there's like a specific seizure phenotype in Phelan-McDermid syndrome. I'm sure Sid would agree with, these kids have all different kinds of seizures. And two is that the standard of care for the majority of patients really works well. I think seizures are very scary, and obviously we hear about a small subset of families that have kids with very refractory seizures, but the majority of kids that we see who have seizures, those seizures are well controlled with our standard of care.
Thank you very much. And do we have any other questions? We might just give it a couple minutes for questions to roll in. I should also note, I should have said this earlier, that the foundation, and I believe Dr. Kolevzon might have mentioned this, but the foundation offers financial support for travel and associated costs with the natural history study. So that is something that we offer if anybody's interested. All of that information is on our website. There's also been some interest recently in us compiling some of these guidelines, especially for folks who are in the hospital or in emergency situations, having something under kind of a QR code so that families can quickly scan it, get very official information to share with their physician who may be less familiar with Phelan-McDermid syndrome. So that's something on the horizon. All right, we do have a question in the Q&A. This is a common theme that we get in a lot of our sessions. Thank you so much for an informative conference. Question: how can I get our daughter's specialist to participate in the ECHO program? I've given them the info, yet their response is for you to contact them. Is this possible? And how, in general, how do we get folks, physicians, more engaged in seeking the expert help?
Yeah, this has been a challenge that we've faced. I mean, I think at the beginning it was even more challenging. I would say that it seems that every month, and now we've actually increased the frequency of these calls to twice a month, and we're pretty filled up. But yeah, getting community clinicians to take the time to fill out a brief consultation form and then to spend the time on the call. Yeah, we understand it. It's an obstacle. We don't intend to create obstacles. So one way to circumvent it is certainly parents can fill out the consultation form themselves in consultation perhaps with their clinician. And I'm always happy to reach out directly to clinicians. I have no problem with that. If a parent wants to email me a form directly and say, hey, this is the email of my clinician, here's the consultation form that I've completed, I will email the clinician directly and say, hey, your patient's parent wants you to participate. How's, next Monday at 2 p.m. Or the Monday after, or 2 Mondays after that, because we now meet every other Monday essentially at 2 p.m. Eastern time. So, and we're only, I think, booked for the next 1 or 2 weeks. Well, 1 or 2 sessions. So we have time. And the group's been active, and they have their time blocked. So we're happy to see people. There's no kind of capacity issue on our side. Majority of clinicians that have participated, I think, have felt that it was really valuable. But these do tend to be folks that are like, highly invested and really interested in learning more about, rare diseases.
Thank you for that. I think the answer to the next question is yes, but we have a question. Are adults taken into the study at the Boston Children's site?
Yes.
Thank you. And we do have another question.
Oh, that's nice.
Oh, that's really nice. I guess it's
nice.
more of a statement. It says, to help, this is from Kathy, to help others considering participating in the studies, I want to add that I've been with my granddaughter the 2 times she participated at Mount Sinai, and they were always wonderful and understanding of her needs and abilities.
Well, that's very nice.
That's really sweet.
And if it's 2 times, we want to see her a third, because this is at least 3 or perhaps 4 time points, depending on when your granddaughter started this study.
We have another question that's asking if more participants are needed in the natural history study. How does a family get involved?
So there is let me get the DSC website up, and I'll put it in the chat. You just call, and we've got 5 sites all across the US. So California, Illinois, Massachusetts, Maryland, New York. Pick your site that's closest and most convenient, and we will connect you to their coordinator and schedule it.
And I should say, you can also, if email us if you don't hear back for whatever reason, email us directly, and we're happy to connect you to our local research coordinators and facilitate.
Thank you.
Also, Sue just asked a question about whether adults with guardians can consent. Absolutely, yes. Adults who live in group homes and whose parents act as their guardians, the parents can certainly consent. And actually, for adults in general, we do almost all the assessments remotely. So we're also pretty sensitive to that.
Thank you all for the great questions and for the great presentations. Thank you all so much for joining us.
Thank you.
We'll see you next time.
Bye.
Bye.